Okay, so good morning or good afternoon even, and welcome to our very first bite size of 2025. My name is Catherine Sim, and I am the operations manager at Reverse Rett, and I'm also a parent to Georgina, who's 29 and who also has Rett syndrome. Sorry. So at Reverse Rett, we believe that knowledge is power. As parents of children with rare diseases, we also know that the onus is on us to become the expert on our child's condition, so that when we can effectively advocate for them, ensuring that their health needs are addressed and that they are protected as much as possible from the inherent risks of the condition. Through these bite-sized sessions, we hope to share up-to-date information with you and give you access to experts in the field who can help you fill in the gaps, enabling you to be as an effective an advocate as possible for your loved ones. Now, we do try to keep these bite-size as quick as possible, bite-size for a reason, and we start on time and we try to finish on time. And we're going to answer as many questions as we can in today's session. So it is going to be a little bit longer today than normal. It's normally an hour, but there's such a lot to cover that we wanted to give everybody time to ask questions. If you do have a question, please do make use of the chat function within Zoom, and we'll start collating those questions and then ask them on your behalf at the end. As I said at the beginning, we are recording today's session. So if you do see that you have your microphone on, can you please mute it so that we can keep the audio as clean as possible? Very lastly, we do need to see your faces. So we've had some issues. I don't know if any of you have seen recently in the press that there was a Zoom call was hijacked. And inappropriate material was shared in that call. So we do need to make sure that you are who you say you are. So for those of you who haven't, if you could put your cameras on, I would really appreciate it. And then I get to see your lovely, beautiful faces. Okay, that's lovely. So, as we said, if you've got any questions, use the chat, and then we can ask them on your behalf. So this is normally where I would now hand over to Rachel, and then I would take a giant breath and go, whew, thank goodness that's me finished. Unfortunately, Rachel and Andy have both been struck with norovirus, so you get me today. So I'm going to, in advance, apologise for any words that I can't pronounce. For those of you that know me, I have dyslexia, and so big words I find quite difficult. So I'm going to do my best. So any bloopers, as we say, are entirely mine. So today's speakers are Professor Santosh and Jatinta Singh, PhD. Professor Santosh, as many of you may know, is an internationally recognised expert in paediatric psychopharmacology, treatment-resistant developmental multi-comorbidity, and neuropsychiatric problems in acquired brain injuries. I am reading this off a script, so I do apologise. Childhood dementias and rare diseases such as Rett syndrome, septo-optic dysplasia, mucopolysaccharides, and paediatric neurodegeneration. He is consultant child and adolescent psychiatrist at the Maudsley Hospital and professor in developmental neuropsychiatry and psychopharmacology at the Institute of Psychiatric Psychology and Neurosciences, King's College London. He developed and heads the National and Specialist Centre for International Paediatric Psychopharmacology Research Team and the CIPP Rett Centre, the world's first centre for personalised medicine in Rett syndrome. Jatinta Tinder Singh is Precision Research Manager at the CIPP Rett Centre and Research Fellow at Department of Child and Adolescent Psychiatry at the Institute of Psychiatry, King's College London. Jay came to the team from the pharmaceutical sector, where he worked in a variety of different target therapeutic areas and in all clinical phase doing consultancy and scientific advisory work. To date, Jay has co-authored 10 papers on Rett syndrome, 8 as a first author. Today, we're going to be talking about how changes in the MECP2 led to Rett syndrome, clinical versus genetic diagnosis, autonomic dysregulation, and delayed onset of Rett. As always, we'll leave time at the end for some questions. So without further ado, I hand over to you, Jay.
Sure. Thank you so much, Catherine, for that introduction. I'm just going to see if I can share the screen. Can you all see my screen?
Yes.
And you can see the DNA moving?
Yes.
Sure. Thank you, Catherine, for that excellent introduction. And I have the honor with Professor Santosh for presenting in the Reverse Bitesize. And it's so pleasing to see all the families and the children with Rett syndrome here at this talk. So the title of myself and Professor Santosh talk is From Rett Syndrome from Gene to Symptoms. And the presentation will be basically has a couple of parts. So the first section A, I'm not going to bore you too much, but I'll just touch about genes and methylation. Why is that important? And the next section will be on diagnostic criteria for Rett syndrome. Then we'll touch on more about the actual inherent problems of Rett syndrome. And then we'll talk about the pre-symptomatic stage in Rett syndrome. Why is that important? Touch on a bit about transformative therapies. And the final section will be wrapped up by Professor Santosh. So just moving on to the first part, why is the genes and methylation important? When you come across Rett syndrome, you may have also heard it being coined as an epigenetic disorder. And basically, epigenetics is a mechanism where it can regulate gene expression without it changing the DNA sequence itself. And why is that important? I mean, epigenetics is crucial for a lot of the neurological diseases, and some changes in the epigenetics can be aberrant DNA methylation, disruptions of histone modification, alternate chromatin structure. So this is normally what you see, have your histones being methylated, DNA itself can be methylated. And then when this gets impaired, you have all these dysregulated epigenetic mechanisms occurring. And this has been implicated in a wide range of neurological diseases. And I'll touch about why this is important for Rett syndrome. So broadly speaking, DNA methylation is the most studied epigenetic mechanism. And what I've shown here is a chromosome here and the DNA. If you do a deep dive into it, these are the histones I mentioned earlier on the side, and they have the methyl groups. Interestingly, you have MECP2, which is a methyl binding domain protein, and you may have come across a read methylated DNA. But as you know, that mutation in readers lead to changes in DNA methylation. What has that got to do with Rett syndrome? So Rett syndrome is an X-linked disorder, and the vast majority of cases of 95% of those with classical Rett syndrome have a mutation in the MECP2 gene. It mostly affects females, but it does also affect males of various degrees of presentation. I've had some bubbles here, why it's predominantly usually found in girls, because females have 2 copies of the X chromosome, and the MECP is found on the X chromosome. So females are normally born with 1 normal and 1 change copy. I'll touch about why this is important in the next slides when I talk about this. As I said, boys also have can have a pathogenic MECP2 mutation, they're usually more severe and really reaching adulthood. The gene itself, the protein itself has many functional domains. I'm not going to touch too much about this, but I just wanted to show you that basically they have a very large, they have a lot of different N-terminal, MD2, inter-binding domains. Basically what these do is they help the protein to engage with DNA. That's what all these different domains do. And as mentioned, these different domains enable the MECP2 to interact with DNA sequences, i.e. methylation sites. Now, why is this important? Because if you look at the brain maturation on its own, you have lots of different processes occurring, from neuro migration, myelination, and all these other things. MECP2 levels are rumored to increase during the embryonic period, and they plateau around 10 years of age in humans. Interestingly, they are incredibly expressed in your nerve cells. Actually, and some evidence suggests that the levels of mitochondria in the cells. And as I've touched on it before, females with Rett syndrome have a mosaic pattern of cells, i.e. some cells have a working MECP2 and some have a defective. So what does MECP2 do? MECP2 fine-tunes your neurons. So during early brain development, this is a simplified view of a DNA strand there, and you have all these, an enzyme deposits the methylation sites across the DNA. And what MECP2 is recruititized, and it just fine-tunes these, it keeps them in check and fine-tunes them. And basically the sum effect is it can fine-tune neuronal gene expression. And why is this important? Because I've tried to exemplify what it means here. So this is a motorway, but what I've tried to exemplify, this is your neuronal network inside your brain. And you can envisage that MECP2 is a car going down the motorway, and it has this distinct destination where it has to go. And for it to do that, there's different pathways occurring. So this may be DNA method, although DNA methylation is the most studied epigenetic mechanism, you can have other epigenetic mechanisms, RNA methylation, histone methylation as well. And basically, the sum effect, it helps to make sure the DNA is correctly packaged for gene function. And what happens is that when each of these networks have methylation site, MECP2 is ensured that it makes sure the methylation sites are meant to be where they're meant to be. And part of it does this, it suppresses the activation of long genes, and lo and behold, long genes are longer than 100 kilobases of DNA, and they are meant to be involved in methylation sites, and some evidence has shown that longer genes are suggested to have a higher level of methylation sites and shorter genes, and it just happens to be that longer genes are neuronal genes. So if we look at a neurotypical subject with MECP2, they have a closed chromatin configuration, and what that means is that this is closed, and it can activate the proper DNA machinery to work. So it involves in transcriptional repression and co-repression. What happens in Rett syndrome? I mean, although there are mutations occurring in Rett syndrome, and I just potentially put what are these pathogenic hotspots. So in the gene, evidence suggests there's probably like 8 pathogenic hotspots, and basically what pathogenic is the main core mutations, although the gene itself has more than 300 mutations, but you can group these largely into pathogenic hotspots. And this leads us to an open chromatin configuration. And then if you look at this and this, basically open chromatin configuration, the kinetics of gene transcription are changed. So the job that MECP2 has to do, it can't do it. And this leads to an impaired neuronal roadmap in Rett syndrome. So you may have seen this why in a neurotypical subject that all the MECP2 is fine this way in the neuronal highway and is found in methylation sites. Rett syndrome, this MECP2 gets impaired. Sometimes it doesn't know what it's doing, and then you have the methylation sites don't disappear. It's but MECP2 can't actually find the methylation sites, and it is surmised that the where there's delayed onset of symptoms. I will come across the delayed onset part in the coming sections of my slide. And this leads to the accumulation of these methylation sites, and the failure of MECP2 binding these is thought to contribute to the elevated genotoxic stress and the neurological regression that occurs in Rett syndrome. And why did I talk about so much in genes? And I hope I haven't bored you already at this stage, but the reason why we need to speak about it, because it all starts from DNA, and it goes from chromatin, and then we can find out what the RNA is doing. There's a lot of studies which show that the MECP2 can actually bind with the RNA polymerase, a recent study. So RNA polymerase, or RNA, helps genes become activated, and a recent study has shown that MECP2 helps RNA polymerase to do this. But overall, this leads us to a better understanding of the disorder. We're able to identify what causes genotoxic stress, all down to the network level, and hopefully this will give us a better understanding of the disease phenotype that occurs. Delving more into the disease phenotype of Rett syndrome, there are brain changes that occur in Rett syndrome, and you can see the effect sizes, which means that how strong the effect is. And you can see that in some of the brains in a study which is done in Rett syndrome using imaging studies, that there is a significant volume reduction. And I'll put in the speech bubbles here what each of these do, but obviously this is a very simplified overview. Many of these have more than one, that put them in as more involvement in movement and so on and so forth. If we looked at more of the cell level, what's happening into the neuronal morphology in syndrome? So this is this slide took me ages to do. And essentially what happens is that the neuronal morphology has changed in Rett syndrome. So you have I've tried to indicate a more happy neuron, and in Rett syndrome, the neurons get impaired, and they have dysregulated atypical cell bodies and dendrites with sparser connections. I'll touch upon this a bit later. Interestingly, the studies done in animal models suggest that this is in the absence of neurodegeneration. Looking more into what Rett syndrome from the genetics and the incidence side, so the global prevalence is 5-10 cases per 100,000 people. I mean, this may be a shortfall. Maybe there may be more diagnosis, and there's evidence suggesting that, especially in the UK, there's high diagnostic levels in this. The majority of patients with Rett have a loss of function. So in the gene itself, the MECP2 gene, there may be 300 different mutations, but these can be grouped into the pathogenic hotspots I mentioned earlier. But also, it doesn't have to be MECP2. 80 other genes have been identified that exhibit Rett and Rett-like phenotypes. And this leads on to the couple of points I'd like to make, that individuals may also present with a pathogenic without any overt symptoms of Rett syndrome. A couple of studies which are recently that there's a pathogenic MECP2 in healthy females, and recently in a large endocrinology study showed that females of precocious puberty have MECP2 variants seen in Rett syndrome without any underlying neurodevelopment issues. So what does this all mean? What do you suggest? This means that even if you have MECP2 mutation, you may not have Rett syndrome, And so Rett syndrome is more than MECP2. And I just wanted to show you this slide, that the number of Rett patients, and there's loads of different genes. Some are involved transcription factor genes, some are involved in the synaptic binding of proteins, but there are other pathogenic genes. So the take-home message is that you can have Rett syndrome also without having a MECP2 diagnosis, and therefore the general consensus at the current time is that Rett syndrome, because there's a lot of the genotype and phenotype don't really match, the genetics are poor prognosticators of the clinical phenotype. So genetic testing can help to confirm a diagnosis. And this leads on to the next slide, the part of the talk, which diagnostic criteria for Rett syndrome. As you probably all know, Rett syndrome is a clinical diagnosis. And for classical or typical Rett syndrome diagnostic criteria, need to fulfill these criteria: stereotypic hand movement, gait abnormalities, and partial or loss of complete hand movements. But you also have atypical diagnostic criteria, and for this to have this criteria, you need to fulfill at least 2 of these main criteria, and also 11 of these criteria. But if you notice here, that not all the key cardinal features, although there's some instances of autonomic dysregulation mentioned there, not all of it hasn't been put in. Epilepsy is not included there either. And not all the patients will have all of these and some of these. So even when you're looking at the diagnostic clinical criteria, there are heterogeneity, whether patients have this, whether individuals have this or this. And this gives a more a pictorial representative of what's going on. And so for the main criteria, you have, as I mentioned, partial complete loss of spoken language, and loss of hand skills, and stereotypic hand and gait abnormalities. And the supportive criteria could have all these ones I've mentioned here. And as you see, hand stereotype is one of the cardinal core features of Rett syndrome. Rett syndrome has 4 stages, which may not be all the case. So there's a so-called pre-symptomatic stage, which I will touch on a bit on my next slide, which I put wide. I put an asterisk. I'll discuss why that is. There's a so-called rapid destructive phase, which is when a neurological regression between 12 to 48 months. There's a pseudo-stationary stage, well, so-called symptoms sort of stabilize, and then there's a late end stage motor deterioration occurring. And this leads on to what are the problems in Rett syndrome. One of the key problems in Rett syndrome that which Professor Santosh leads in the CIPP Rett Center is autonomic dysregulation. In simplistic terms, you can look at the autonomic dysregulation as an imbalance between the autonomic nervous system in the human body. Autonomic nervous system is split by the sympathetic and the parasympathetic. And what I've shown here, if you have 2 cases, so in one of the features of Rett syndrome is brainstem immaturity, and that has a role in how autonomic dysregulation manifests. So on one hand, if you have an individual with brainstem immaturity, epilepsy, and breathing dysregulation, they may have more severe autonomic dysregulation if you compare to someone who had brainstem and just GERD, for example. And the key problems in Rett syndrome, as I mentioned, is autonomic dysregulation. It seems to be a critical issue for the patients for individuals with Rett syndrome, and it's the inherent brainstem vulnerability in Rett patients leads to impaired cardiovascular control. And I was trying to envisage it here. This is I've marked here with the brainstem immaturity. and you have a waxing and waning of the seesaw effect of the parasympathetic and autonomic system here. You have epilepsy occurring, which is the evidence is unclear, but what we are able to glean from this, that is ranges from 80–60%, but obviously a lifetime prevalence of up to 90%. There are cardiorespiratory problems. I mean, there are more than a dozen breathing phenotypes in Rett syndrome, from feeble to shallow to forceful breathing. Some of these conditions, of these breathing phenotypes, when combined with others, individuals may be more vulnerable than others. About 18% of patients also have cardiac abnormalities and QT prolongation, but there's also evidence suggests that they may have, and the Italian study has shown that there may be a cardiac anatomical defect in Rett patients, but the sample size is still rather small. So as I mentioned, that Rett patients may have, because they're autonomic dysregulation, they may have cardiac respiratory vulnerability, and this leads to Rett patients may be at high risk of sudden death. And I've tried to highlight it in this diagram here. So individuals who may present with potentiation factors, so for example, sudden breathing difficulties and combined with generalized epileptic seizures and QT prolongation, they may be at high risk of sudden death. And I've sort of mentioned it here, is that you have electrical instability of the cardiovascular system, which can lead to ventricular arrhythmias and acute cardiorespiratory dysfunction, and lead to sudden unexpected death. There are factors that may precipitate this. So medications that may cause respiratory depression, infection, and sepsis, seizures, and also medications that can prolong QT. As I mentioned, intervention events such as sepsis might enhance underlying autonomic impairment and precipitate acute cardiac respiratory dysfunction. Rett patients may also have sudden unexpected death in epilepsy, otherwise known as SUDEP. What is SUDEP? SUDEP is a death which occurs suddenly or is unexpected in children with epilepsy. SUDEP itself is a nebulous entity because there's not a lot of evidence what SUDEP actually is. So there's a lot of overlapping constructs. For example, there's SIDS and SUDEP. And you may have genetic risk factors. I mean, although the gene for SUDEP is unknown, there's likely to be lots of different factors interplay, from genes to multiple phenotypes such as epilepsy and cardiac arrhythmia. But as the avatar shows, you may have SUDEP, and SUDEP can even occur even in epilepsy that is relatively benign and well controlled. And also, the definition has recently been updated of SUDEP plus, for example, taking into account if a comorbid disorder exists, such as prolonged QT. But as I've mentioned, what has all this got to do with Rett syndrome? Because individuals with Rett syndrome are high risk of SUDEP. The key risk factors of SUDEP are 3 or more GTCs per year, and followed by more than 13 any type of seizure in the 12 months. Developmental delay is another weighted risk factor of SUDEP, and this is done on the SUDEP risk inventory, which is a 7-item scale, and these are the most heavily weighted items. Polypharmacy is a heavily weighted item on the SUDEP risk inventory as well. So individuals taking more than 3 anti-epileptic drugs. And if you look at Rett syndrome, all these factors also align with Rett syndrome. Rett has underlying brainstem vulnerability. It has individuals may have developmental delay. They're on multiple medications and epilepsy as well. So could proactive surveillance of the autonomic profile in Rett patients, could we manage epilepsy better and reduce the SUDEP risk? This is quite a busy diagram. I just wanted to show you what this suggests is that there's a lot of events leading up to SUDEP when a seizure occurs, but before the seizure, the pre-ictal phase, and when the seizure occurs and the post-ictal phase. And I've highlighted some factors, what can occur, what precipitate. But in the end of this stage, we want to prevent it leading to this acronym, which is PGS, post-ictal generalized electroencephalogram suppression. All these pathways leads to this. But the issue is that we know SUDEP occurs and it changes over the period in Rett syndrome, but we do not know whether tracking these events would help us detecting early events that would prevent leading to the PGS and onto SUDEP. So the take-home message is from the study that Professor Santosh and I did was that Rett patients are at high risk of SUDEP, but it's notoriously difficult to predict. Some of the other problems, as you're well aware, is the movement disorders in Rett syndrome, and this is basically a cross-section of a normal of a brain, which is a different regions to be involved in the movement, mostly lying in the motor cortex. And when we do a deep dive into this factor, what I've tried to show here is that there are a lot of neuronal networks involved and a lot of places. And what we've done, we've teased together various information and put it in a meaningful format. What could be dysregulated in Rett syndrome? And it suggests that the striatum is a key neuroanatomical region which is affected in Rett syndrome, and the affection of with medium spiny neurons which are affected in the cerebellum is affected, and you could see that these what is dysregulated pathways. So as I mentioned, there's a lots of neuronal pathways which are associated with Rett syndrome and multiple interconnecting pathways, but perhaps this slide would break it down into a more easy digestible way. So I may have mentioned earlier that these are the different stages in Rett syndrome, and in the earlier stages you may have hypertonia occurring, and stereotypies tend to last across the lifespan. You have Parkinson-like rigidity and tremor occurs in the later stages, and then you have dystonia, which seems to occur at the same phase. Rett syndrome has both physical and mental illness. I touched about the physical illness, but there's the mental illness as well. This is a study we done in 65 patients in the CIPP Rett Center, and as you can see that we showed that generalized anxiety disorder was the most common neuropsychiatric disorder. But also if you look at the other disorders, epilepsy is incredibly common, GI issues are incredibly common as well. The CIPP Rett Center specializes in EBAD, emotional, behavioral, and autonomic dysregulation. Why is this important? So this is a diagram of what EBAD is. So you have the behavioral component, and you have the emotional component and the autonomic component as well. EBAD is seen in treatment non-responders and those who have functional disability, and is frequently accounted in rare disorders. It's really hard to manage. It's more difficult to manage the behavioral dysregulation, emotional dysregulation than it is to target an autonomic dysregulation. So with EBAD, there's a disorder of multiple overlapping symptoms, and the way we try to manage EBAD in the CIPP Rett Center is by targeting the autonomic component. So this slide just shows how we may target the autonomic component, and as you can see, there's a lot of dysregulated neuronal networks, and the brainstem immaturity leading to autonomic dysregulation in Rett syndrome. And what this shows is that And some of the treatments that the CIPP Rett Centre has used is these highlighted here. And interestingly, we can able to target the autonomic dysregulation by using our physiological data using the wearable devices to monitor the electrodermal activity. Electrodermal activity is basically your sweating response, otherwise known as your skin conductance, or scientific terms is galvanic skin response. It's a good marker of sympathetic activation. So I've tried to, so when your EDA is high, it means your sympathetic nervous system is more stressed. And if you look, it's like a physiological seesaw. So this avatar is representing when your EDA is really high. So it's heavily skewed to the sympathetic component. So once we talked about the problems in Rett syndrome, I'd like to talk a bit about the prodromal stage. And this is, you may recall when I spoke about the pre-symptomatic stage and why there was an asterisk. Before I talk about the pre-symptomatic stage, which alludes that there's a seemingly normal stage before regression occurs in Rett syndrome, but is it really normal? And why do we have to really think about this? So in 2021, there was a landmark study done in animal models. And basically, this is a healthy, so the overall hypothesis was done that this is healthy development. This is a development in Rett. And if we can, so what this study showed that pre-symptomatic training in a mouse model of Rett syndrome can delay the onset of symptoms and maybe mitigate the severity of the neurological regression that occurs. But that's in an animal model. Have any studies been done in patients regarding this? So there was a study which came out a couple of years ago, which looked at environmental enrichment. This study was done in 12 girls with MECP2 mutation, and the intervention comprised of motor learning, exercise, supplementary with social, cognitive, and other sensory things. I will talk about what these specifically were. And the take-home message from this paper was that enriched environments were associated with improved gross motor skills and a decrease in blood BDNF levels after 6 months of intervention. So essentially, behavioral interventions such as environmental enrichment may reduce the functional deficit in Rett syndrome. This was the take-home message of this paper. And before I go into, I will delve a bit more deeply into what this means in the next slide. But basically, BDNF, brain-derived neurotransmitter factor, your nerve cells really like these. And as I've tried to, if the levels of BDNF increase, they're more likely to maintain the structural integrity of your nerve cells. And what is the components of this environmental enrichment in these 12 Rett girls, which is hypothesized to increase BDNF? The activities included a lot of balance and walking high volume practice aiming to increase BDNF, and each motor activity was supplemented with like visuals such as toys and auditory, taste, vestibular, and so on and so forth. I've been going on about BDNF. What does BDNF actually do? BDNF, looking at a deep dive, is BDNF receptors, activation of BDNF receptors affect brain development. And this is a neuron I've showed here. This is a presynaptic neuron, postsynaptic, and this is a synaptic cleft. BDNF can be trafficked at both sites, stored in vesicles in the presynaptic nerve cells, and then eventually gets released into the synaptic cleft. As I've seen it, it binds onto BDNF receptors, and then the BDNF receptors go on and find their own way. And so essentially, what I want to show here is that BDNF is important for brain development. It does this via postsynaptic and presynaptic modulation, the BDNF gets released from presynaptic cells, and it's involved in a process known as Hebbian plasticity. And basically what Hebbian plasticity is that the presynaptic neuron becomes constantly activated, and this is meant to potentiate your postsynaptic neurons, and that is meant to lead to potentiation of other neural networks involved in memory and other factors involved in being. So in a nutshell, what the study showed, that BDNF is improving gross motor skills, and when you have BDNF, it activates gene transcription, and two major genes are involved. These genes are phospholipid C, gamma, and multi-gene activated protein kinase. And essentially what these do is synaptic plasticity and postsynaptic translation, and they help your neurons become in a more happy, peaceful state, such as they foster neuronal homeostasis. But the study needs to validate it in a much sample study, a larger sample. It was only done in 12 girls with Rett syndrome, so this is just done in 12. So we may not know whether environmental enrichment works in all groups of Rett syndrome. This is a study, so it has to be validated in larger sample. So I've talked a bit about what BDNF is, the time window, pre-symptomatic stress. What has this all got to do with the because we think that if we can test and find out what's going on the pre-symptomatic stage, we may be able to prevent the impairments in neurological, maybe decrease the genotoxic stress, and maybe mitigate neurological regression occurs. Despite the contrary evidence that there's a lot of literature out there that pre-symptomatic stage is relatively normal, we don't think that's the case. We do not think that the period before regression is not normal in Rett syndrome, and the general consensus is that it is seemingly normal, but when you tease apart the evidence base, there are slight subtleties in hand movement, the facial gestures, communication, and saccades as well. But then one can argue about, if these are such subtle hand movements, how do we pick these up? And this is why we can use the boon of digital phenotyping. Now, digital phenotyping is not new. It's been used for a couple of years to separate the pre-symptomatic states compared to individuals who are neurotypical individuals and those who have neurological diseases that do actually have overlapping symptoms of Rett syndrome. For example, you have digital phenotyping has been used to identify pick-up saccades and finger stereotypies in Huntington's disease, which is a neurodegenerative disorder, unlike Rett syndrome, and gait impairments and spinocerebellar ataxia. It's been used to identify speech biomarkers before the main onset of the more serious speech problems in Parkinson's disorder. And recently, a couple of studies come out that digital behavioral phenotyping can be used for early detection of some individuals of autism spectrum disorder. How would we do this in Rett syndrome? So what we think is that if we could compile a digital archive of videos and images of individuals of Rett syndrome from birth, at the moment, if we could have this at the moment, if that's a possibility to do, we could compare it to development milestones of neurotypical children. And now, with the boon of AI and machine learning, we would be able to quantify multiple Rett-like behaviors in prediction models that would allow early detection of Rett-like behaviors. The CIPP Rett Center is leading the way in artificial intelligence and trying to pick up in prediction algorithms and rare neurodevelopmental disorders. So we're well placed for this. We will be able to pick up before of the overt symptoms appear, even when there's a multiple different presentations amongst the patients. And this sort of the diagram just depicts it here, that if we're able to mine and pick up all these, have an archive of all these, if we can have a digital repository of all these from birth, we can use the digital phenotyping, see what's really going on before overt symptoms appear, and using the power of machine learning and AI, we'll be able to lead to improved diagnosis. So overall, what this suggests is that genotyping might just improve early diagnosis, reduce genotoxic, and lessen the severity of neurological regression in Rett syndrome. I'm just going to touch a bit about transformative therapies before I let Professor Santosh go in. The central nervous system is implicated in most rare diseases, and you can see it's very large amount. And I wanted to show you this nodal network. So the spheres indicate how much weight is attributed and how thick these lines are. So for example, here global developmental delay is associated with the neurodevelopmental sphere, and seizures is also associated. But what happens in Rett syndrome? This just shows what happened. And this, if you look at the broadly speaking, when you look at the neuropsychiatric domains, what affected Rett syndrome encompasses the whole gamut of these. I mean, there's mostly all the spheres are largely affected. So what does that mean for reversal of MECP2 impairment? I just want to bring back to my slide here is that preclinical animal models have shown that the disorder can be reversed in the absence of features of neurodegeneration. So it may be that the neuronal system in Rett may be sufficiently intact to support functional restoration. This could be pivot us to say, could this be amenable to transformative therapies? I spoke about mosaicism in my earlier slide, that females have a mosaic pattern of cells. Some cells have a working MECP2 and others have a defective protein. And this is what mosaic actually is. And I know my slides have been incredibly complicated, and I appreciate. So basically, each cell, this looks like the brain, each cell in the brain has a normal gene and a mutated gene. But this may have an issue for transformative therapies. Why is that? In MECP2, Rett syndrome being a neurodevelopmental disorder, they have dosage-sensitive genes, and MECP2 is no different. So this I've looked at. This is a neurotypical subject. We can imagine it like the Goldilocks zone, like if it's too hot or too cold. So in Rett syndrome, if you have too little of the MECP2, if it's not tightly regulated, you have Rett syndrome. Too much causes to MECP2 duplication syndrome, and it doesn't take much to cause MECP2 duplication syndrome. In fact, this is studies done from animal models. About a 3-fold expression is lethal, and maybe 1.6 to 2.4 times the level of expression of MECP2 can lead to MECP2 duplication. MECP2 duplication syndrome is a syndrome in its own right. It's exclusively in males. It's rarer than Rett syndrome, and it has significant overlap with Rett syndrome. So just to finalize, any potential therapy in Rett syndrome needs to take this into account. If we have too much, you lead to MECP2 duplication syndrome. If we have too little, it goes to Rett. And this is a problem. So we have too much MECP2, too little is Rett. So this means expression levels are tightly controlled. this avatar is in a really good place because he was undergoing transformative therapy and they got the expression level correct. But unfortunately, this poor fellow hasn't bowled too well. The MECP2 levels were all wrong and they got MECP2 duplication syndrome. So now I'd like to invite you to Professor Santosh, who will come and continue the rest of the talk.
First of all, thank you, Jay, for an amazing presentation. He's sort of covered areas that I think it usually would take years for people to understand and be able to synthesize. So I'm very grateful for him having made this endeavor. Yes, many of the things are complicated, but that's what we're here for, to discuss. If you have questions, please don't hesitate, and we're more than happy to discuss. So what I'm going to be focusing on is just the very practical issues that are more clinical stuff, and then we can have a conversation about the different discussions subsequently. Okay, so the first thing is to just look at it from the perspective of what is precision medicine, how do we do that in our center, which is the CIPP Rett Center, which is, I think, one of the largest centers in the world. And we probably are unique in the way that we are one of the few centers where we see patients with Rett syndrome every day. Every working day, we have a clinic, so we see patients every day. So that's one of the things. So when we're looking at it from the perspective of precision medicine, around 50% of rare diseases affect children, and most of them have neurodevelopmental issues as such. In terms of rare disease, when the brain is involved, you have neurodevelopmental problems. The issue is, how do we manage to decide who should be given what treatment and for what symptoms? So that's where precision medicine comes in, when it comes to using multiple sources of information to be able to come and to make some clinical decisions, which might be useful in terms of deciding what we do for a particular individual at a particular time. So first of all, what we do is we're looking for monitoring of adverse treatment reactions. So we're using things which are to do with physiology and pharmacogenomics and so on. It helps us to optimize treatment responses for individuals. In terms of physiological data in real time, so we can identify whether there's something that's happening at a particular time in the day. So that we can actually understand, is there something we need to introduce which is not medication-wise? So, for example, if we identify, as has happened in real in the clinic, some of the individuals where we find that at the particular periods in the day, let's say around between 3 and 5, there's significant difficulties taking place, and in the morning between 8 and 9, there's something very specifically happening. And it's happening and it's repetitive. It's been done multiple times and we're seeing that there are problems in exactly those periods. Then it allows us to actually go back and find out what's happening during that time on weekdays. And then we realize that it's actually the time when the patient's being transported to and from, let's say, educational setting or a residential setting. And if that's the case, then we can recognize that it is either more stressful, or there's something that's happening during the process. Maybe it's to do with the wheelchair in terms of how it's being transported into and out of the taxi. So it's things like that that helps us to actually look at it based on data, the data that is actually being collected continuously. And of course, when it comes to pharmacogenomics, which allows us to look at it from the perspective of gene-drug interaction. Is there a particular thing that is happening in this particular individual? That means that certain types of medicines may not really work. Or if we use certain types of medicines, they may end up having more side effects. So that sort of information is collected. And of course, when you look at everything together, you're looking at it from a multi-source neurobiological mechanism. So it could be to do with the brain, it could be to do with genes, it could be to do with the kind of symptom presentation. It could be to do with physiology in terms of breath holding. They could be to do with environment. It could be any of these features which are actually being modulated when it comes to symptoms and how they are showing impairment and improvement or otherwise with treatment. So What do we do in the CIPP Rett Center? We fundamentally, it's a national service, and we see patients from the whole of the UK, including EU now. We're increasingly being asked to see patients from all over the world. And what we do is our focus is on trying to get information which allows us to use some strategies from precision medicine to help risk stratify patients. So in terms of what are the risks associated, trying to help and look at the patient from a holistic perspective, and also help with repackaging medical information in a manner that various specialists would be able to provide the right support for. And that's the kind of thing that we don't claim to be the experts in every area of that's affected in Rett syndrome. Rett syndrome is multi-system involvement is there. It's multi-morbid. But what we do focus on are aspects like the EBAD that has been discussed before. It's emotional behavioral autonomic dysregulation. So because autonomic dysregulation is central to quite a lot of symptoms, including gastrointestinal, including breathing, including sweating, peripheral, cold extremities, all of those kind of things which can be present along with behavior and emotion. And of course, what we're looking at is in terms of personalized care to improve outcomes and using various strategies like pharmacogenomics and sensor-based strategies in terms of biometrics. Now, what are the kinds of comorbidities that are commonly seen in Rett syndrome? If we look at it gastrointestinal, what you can find is that at least 9 out of 10 patients will have some GI symptoms. So in terms of the constipation, 80% of the 8 out of 10 would have it. Where when you're looking at reflux, we're 4 out of 10. So we're talking about 40%. And these are symptoms that should be targeted. And of course, when it comes to swallow, 4 out of 10 would have problems in swallow. And these are all important aspects to be considered when you're looking at risk across time, because these are not static phenomena. Someone may have perfectly good swallow, but in 6 months' time, they may actually have a problem with swallow. So it has to be longitudinally mapped. And so that's one of the things that the team does, which means that they're able to longitudinally look at when someone's symptoms have actually started appearing or changing as such. And of course, abdominal bloating you can have for various reasons, including air gulping. So you actually have to understand the context of it, and then we consider strategies, and we repackage information in a manner that could then be seen by the general practitioner, the gastroenterologist, and then appropriately managed. So what we come at it is from the Rett specific information that many specialists may not actually have because they see Rett syndrome rarely. Coming to endocrinopathies in Rett syndrome, this is because of changes in hormonal profiles, which are present in very many conditions and many rare diseases, including Rett syndrome. What happens is that many of them can have short stature. So it tells you roughly 40%. When it comes to weight issues, you can see around 40% can either be very low malnutrition, or some of them can even be obese. But 1 to 2 out of 10 could actually have precocious puberty. And as Dr. Singh mentioned, the association of MECP2 and precocious puberty is starting to being explored, even in the absence of Rett syndrome. And so again, these are issues that are, as science progresses, we'll be in a position to understand more and try and deal with things. The advantage we have in our clinic is because we deal with multiple rare diseases, and we also have a background in understanding what happens in physiological and psychiatric conditions like anorexia and restrictive eating. And so in terms of understanding growth in rare diseases, we are actually quite well placed in trying to help with understanding what needs to be done. And again, when it comes to menstrual irregularities, there are issues which need to be dealt with. We link up with the appropriate gynecologists and so on, and help with making the key to understand what's happening in the context of Rett syndrome and what Rett syndrome can and how it may contribute to the issues. Then comes in terms of the orthopedic comorbidities. Here, scoliosis is very common, as everyone knows. Foot deformities are very common, and hip displacement is in roughly 30% of patients. So when someone is in pain, one should really be looking at all causes, including things that may be missed, because hip displacement is something that can often be missed because someone may be wheelchair bound and may not really be looked at carefully, and that might actually lead to quite a lot of distress. When it comes to scoliosis, when it comes to post-scoliosis surgical complications, by definition, when you look at all the in terms of Rett patients per se, and when you compare it to match controls and other kinds of neuromuscular scoliosis, what is clear is that there's a much higher incidence of pneumothorax, which means that problems with the lung post-surgery, and there's a high incidence of pneumonia. And these are all things that probably are related to Rett syndrome itself because of the vulnerability that is present, and in terms of the inability of the person to be able to have a good respiratory function as a consequence of breath holding and other things as well, and hypotonia, which means that the diaphragm is not moving properly, and so therefore you have more problems. And there's a higher incidence of respiratory failure, and also other multi-system involvement, including renal failure and so on. So surgery, when someone's going into for surgical, major surgical procedures like scoliosis and so on, actually having a conversation with a team like ours, and then we planning it with the surgical team, and so that they're aware of what are the main issues that could occur with Rett syndrome, is probably a good thing to do. Again, we are not the experts in this area. However, we do understand Rett syndrome and how it could complicate post-surgical states. And so with that, I end the presentation, thanking all of you who have been patiently listening to this rather, complicated presentation. However, I hope that it's been of some use, and both Dr. Singh and myself are here to discuss any questions and try and explain anything that you'll want to.
Kate has asked, do you think if breathing issues could be put under control, then seizures might never start?
So in terms of breathing is a big issue, respiratory, and it's probably one of the areas where a lot of focus has not been provided clinically. And in terms of breathing difficulties, there are many different types of breathing problems. Some individuals may be shallow breathers, so most families may not even pick up that they have a breathing problem. Some others may be having air gulping, or air puffing. Some others may have breath holding. Some may have breath holding with cyanosis, going blue. All sorts of various presentations are possible. However, it's an area where, as a team, we've been looking at it with respect to understanding the autonomic component of why this may be happening, and seeing whether by modifying autonomic function and making it more normal, whether the breathing difficulties can be improved. And that's something that can be done. And of course, one of the issues, the relationship between breathing and epilepsy is something that is, it's like a chicken and egg scenario. The more breathing difficulties you have and your breath holding, the more likely you are to trigger pre-existing pathways that might lead you to end up with an overt seizure. However, the other way around is that when you have a seizure, the seizure may spread to the brainstem, which might actually lead to the breathing difficulties becoming even worse temporarily during the seizure. So it's a complex scenario, but I think it's an important one to focus on. And there are medicines that might help breathing difficulties. We've we have looked at certain molecules that might help regulate breathing, and we are in the process of submitting the manuscript for publication. So at this point in time, what I would say is that there are options to look at regulating brainstem function, especially of the cardiorespiratory center, which might make things easier in terms of regulation of breathing.
She's expanded on the question. You might have covered it a little bit then, but she's also said most anti-anxiety medication seems to raise the seizure threshold. How do you pick which medication to use to improve breath holding but not increase seizure activity?
So in terms of anti-anxiety medication, it's not necessarily that most of them increase seizure threshold. There are certain types of anti-anxiety medications that might do it. Fundamentally, when you do pharmacogenomics, we actually get to see whether someone is more prone to certain side effects, including whether they are what we would call as slow metabolizers, which means that they don't break the medicine down quickly enough, certain medicines. And if that's the case, even though you're using doses that would be considered normal, they may actually be accumulating the medicine in the body much more. And if that's the case, then that can lead to side effects, including lowering the seizure threshold. However, as a team, we use a strategy called the minimum effective dosing strategy. What it means is that we start with the smallest possible dose for any patient, for any drug that we start, including anxiety medicines. And what it means is that we may start with roughly 1/8 of the dose that we might actually think is needed for the person. And then we increase it roughly by 1/8 of the dosage every week after having discussions with the family and seeing that the patient is doing well or not. And so if we only increase it to the point where if there is any side effect that comes in, then we actually try and stop the medicine or reduce the dosage to get it to the point that we can actually manage it. But as has been highlighted, the biology of Rett syndrome is very complicated because of methylation and all of the consequences that BDNF are the various strategies as such. And so one needs to understand that it's not an easy fix. It needs to be done at an individual patient level. And that's why a center like ours exists. And it's always decision making. So it's a shared decision making about what needs to be done and how we do it. And we actually look at it from that perspective.
Brilliant. And one more question. Could you explain what precocious puberty is?
Okay. Precocious puberty is basically puberty coming on earlier than expected. So you may end up having a girl starting to have breast development, hair under the armpits, and pubic hair, and also starting to show signs of early menstruation. So those are the kinds of things that would be considered early onset. Early onset, it's different in different ethnicities and so on. But often 78 years of age is considered as something that one would be looking at, and it needs to be taken in context of weight and so on. Someone who's very, very low in weight, the chance of the person actually being able to have menstruation is low. And so therefore, it has to be taken into account, and the gynecologist would be involved in the decision-making about what it is, and endocrinologist. And that is something that, as I stated previously, both of us have stated previously, it's an area I think we will learn more about, because MECP2 mutations, which do not lead to Rett syndrome overtly, seem to be a finding in these cases of girls who show precocious puberty.
And another question from Abigail. She says, regarding CIPP, do you believe that all people with Rett syndrome who have epilepsy are at a dangerously high risk of this? And is there anything we as parents can do to try to mitigate the risk?
Okay, I will let Jay come in as well on this, because there are various things that we've published on. and then I'll take it from there.
Yeah, I think so what I've tried to explain that there is a risk of SUDEP in patients who individuals with Rett, but it's hard to predict when the SUDEP will occur because there's such a wide spectrum in these patients. I mean, the time course of epilepsy in patients is not uniform. Either it sort of waxes and wanes like across the lifespan. So while there may be epilepsy, but the risk of SUDEP may be there. But if we have one patient who has more of a severe cardiorespiratory phenotype, they may be at a high risk of a patient who doesn't have the same phenotype. So I think while SUDEP risk is there, it has to, as Professor Santosh said, it has to be done on an individual basis. Some patients may be more at risk, and we have tried to publish using watch data whether we can pick up biomarkers before the seizure occurs or during the seizure and how we can prevent it. But we know that a lot of the evidence suggests that SUDEP is a probabilistic entity, which basically means it can happen on its own right. So you may have all these underlying features of severe cardiorespiratory phenotype, and some other patient may have, but I think it's not uniform when it occurs. In terms of the medication, I'll let Professor Santosh talk about that.
I think what we have to look at in terms of SUDEP is that, as I said, I want to make it very clear, I'm not a neurologist. So neither of us should be thing. But what we have done is that we've looked at existing data and we've published based on that to understand the phenomenon. And what is clear is that in Rett syndrome, because of the heterogeneity of Rett syndrome, types of mutations are very different. The prediction of whether someone will even have treatment-resistant epilepsy, meaning that the epilepsy is not under control despite multiple different types of anti-epileptics being tried, that itself is difficult to predict. And it could be some individuals start having seizures very early on, some individuals start having seizures slightly later, and so on and so forth. But taking all of that into account, the kind of things that one would be looking at from the perspective of general SUDEP principles is individuals who are on more than 3 anti-epileptics at the same time, individuals who are prone to having long QT already, individuals in whom seizures can have a tendency to spread to the brainstem, affecting the cardiorespiratory center as such. Individuals who are requiring rescue medication multiple times and end up with prolonged seizure activity, and so on and so forth. So these are various things that could sort of pick up who are the ones who need to be monitored in greater frequency and assisted. However, in terms of neurology, the neurologists are the ones who would be best placed to deal with this. In terms of specific issues about medication, whether it is Briveristim or whether it is Keppra as such, having any specific issues to do with breathing, the only thing we can say is that the greater the chance of a particular medication leading to sedation, high sedation, means that the body may not be able to pick up in the need for things. So it has to be taken into account as such. So oftentimes it's to do with drugs which are benzodiazepine-like based, so like clobazam and other things. But these are medicines that can actually be life-saving. So I do not want this to be misinterpreted and misunderstood. These are the things that have to be taken into account as one of the very many factors that one has to look at. And the other thing to understand is that having actually good management of reflux, of hypersalivation, of aspiration, the chances of aspiration, often there is the fatality is not because of just seizures or anything. It's to do with the consequences of complications of aspiration that lead to sepsis and then end up with complications which then lead to to fatality. So seizures are important to be looked at, but at this point in time, I would say that it's very difficult to predict who is the one who's going to end up with SUDEP, because the data of SUDEP specifically in Rett syndrome is lacking. So the SUDEP information we are talking about is in general.
Thank you. I'm about to butcher the pronunciation of these drugs, but a question from Anna is, does
Levetiracetam, yes.
or brivaracetam
Levetiracetam,
have
yes.
bad effects on breathing?
Yeah, I had seen that pop up, the question pop up, and as I was saying, is that
I was dreading this one.
is that the issue is that all anti-epileptics, no child is or no individual is going to be started on an anti-epileptic unless there is a need for it, because untreated seizures has got its own complications and fatality arising from that. So the risk-benefit ratio is about, do we need to treat something as such? And seizures are something that needs to be treated. And all I can tell you is that from data that is available within our data set, the common anti-epileptics that are used in individuals with Rett syndrome remain sodium valproate, carbamazepine, lamotrigine, Keppra or levetiracetam, and so on and so forth. But the issue is that neurologists will be deciding on which anti-epileptic to be used based on the type of seizures the person has. So it's not one anti-epileptic for everyone, because some may have mainly generalized tonic-clonic, some may have generalized tonic-clonic plus complex partial, some may have predominantly myoclonic or absent seizures. So it depends on what kind of seizure. And so the way we deal with it in the clinic is that we work with the network of experts. So the individual may have a neurologist locally who's dealing with it, and we then work with the neurologist to see whether there is anything that needs to be done, which if they contact us and ask us to have a conversation about Rett-specific issues, we are then more than happy to have that conversation to see whether there's anything that we can provide assistance in terms of helping the person make the decision about changing. And these are not, these are usually neurologists who may not be working with Rett syndrome a lot. The ones who are dealing with Rett syndrome regularly, they are individuals who will actually be having the expertise already. But what we are talking about is looking at it from the perspective of in order to be able to manage seizures, if what's happening is that the child is extremely drowsy most of the day, and then because of the hypersalivation, they're actually choking, and they've got a poor swallow, and they're ending up in hospital multiple times because of aspiration, then that's an issue that we have to look at it as a network in terms of understanding it holistically as to, is there any other option that can actually be done which might make the person be a bit more less drowsy during the day, so which allows them to cough and to manage. So it's that sort of thing. So I'm again making it clear that we are not the experts in epilepsy, but what we are doing is we look at the patient's profile holistically, repackage medical information in a manner that we can then give families to go back to the specialists, and us included, going to the specialists to say, this is what the profile is in this patient at this point in time. So we just want to find out whether there is anything else that may need to be done because of X, because of increased sedation, for example, or something like that. And so that's how the center works, try and keep patients safe.
Thank you. And I'm aware we're running low on time now, so I've got one more question from Yvonne, and she's asked, pneumonia and chest infections are a leading cause of death in Rett. Could you tell us what work is being carried out to look at the causes and preventative measures to help families?
So in fact, it's a good time to have the discussion, because we have looked at, because many of the patients are registered at the center, and we've had quite a few deaths in the last 24 months or so. So what we've been looking at is what are the common things that have been common to, what are the features of individuals who've passed away. And we are now in the process of developing a measure to look at risk in individuals with Rett syndrome. So which we will then be hoping to roll out using the health tracker to be completed every 6 months so that we can actually stratify and identify those who may be at risk. However, this is a research question. We cannot be certain that it will make a change, but we're hoping that as we collect data, we will be able to use artificial intelligence to be able to segregate and identify and predict who may be at greater risk. So this is, and as part of that, one of the common themes that have occurred when it comes to mortality is aspiration pneumonia, inadequate ability to treat the septicemia afterwards, leading to problems, and then leading into fatality. So therefore, the issue about being able to identify risk factors in terms of what's happening. So as I highlighted already, hypersalivation with a first swallow leading to choking or having aspiration, silent aspirations. These are things that need to be looked at. The second thing is that if someone is actually has become very unwell, one of the first things that have to be done is it's a sudden onset, becoming very unwell. When they go into the A&E, it's possibly a good thing to get an X-ray of the chest done, because it's very likely that it's actually aspiration pneumonia that is not being picked up in time, because it takes long for people to get to that because they may not understand Rett syndrome well. So these are all things that we are actually looking at, and hopefully we will be publishing in this area, and then and being able to train families what are the things that we could do. But at this point in time, again, we're trying to link up with the respiratory physicians to see how we can actually roll it out in a manner that would make sense to get the best for families so that they can do it at home before anything happens.
Brilliant.
Yvonne says, thank you. That's very helpful. Professor Santosh, there are another couple of questions that we just don't have time for. So if it's okay with you, I will send those to you separately, and then ask for a response.
No problem at all.
So, that has just, information has just been pouring into my poor little brain there. Thank you so much. So informative, and I love the slides, Jay. Never stop doing the artwork.
Absolutely.
They were brilliant. So thank you to everyone for attending today's session. As always, it will be available on our YouTube, Reverse Rett YouTube channel. Please remember to like and subscribe. We're very much looking forward to seeing some of you at our upcoming LEAP weekend in Manchester in May. Tickets are still available on our Eventbrite page, and we're happy to share that with you. Big thing tomorrow is Rare Disease Day. Now, we loved our Valentine's quotes and images that we all shared back in Valentine's, and this year Wesley has not let us down and has made a fantastic Facebook frame. Keep an eye on the socials tomorrow, where you'll be able to upload a picture of your loved one with Rett syndrome, and both Evelina and Wesley will wrap it up in a beautiful rare disease frame for you to share on Facebook. Last thing, we all look forward to seeing you in March, Thursday the 20th of March, in fact, with Dan Lumsden for our next Reverse Rett Bitesize. So thank you again, Professor Santosh and Jay, for a really, really interesting and informative session. And to everybody at home, I hope you've enjoyed it as much as I have. And thank you all for your time. And we look forward to seeing you again soon.
Thank you.
Thank you. Take care.
Bye, Jay. Bye, Santosh.
Take care. Bye-bye.
Okay, bye then.